Hello, everyone, and a very warm welcome to part 3 of the ISSUP Stimulant Use webinar series. Thank you for joining us. I am Ben Vista, Director for the Philippines National Chapter at ISSUP, the International Society of Substance Use Professionals. While we are waiting for a few more to join us, I will begin by saying a little something about ISSUP. ISSUP is a membership organization with over 20,000 members worldwide working in the fields of substance use, prevention, treatment, and recovery care. If you've not already done so already, please head over to our website, issup.net, where you will find information on how to sign up for free membership. Our website also has a wealth of resources and publications for you to enjoy. You can also watch recordings of past webinars and see future event listings. I'd like to thank the ISSUP staff for providing the technical support for this event. Today, we journey into featuring examples of stimulant use treatment programs with speakers Professor Richard Rawson and Dr. Mariano Hembra. A very warm welcome to you, Professor Rawson and Dr. Hembra. It is a great pleasure to have you with us today. Our first speaker will be Professor Rawson, and he is a professor emeritus at the UCLA Department of Psychiatry and a research professor at the Vermont Center for Behavioral Health at the University of Vermont. He received a PhD in experimental psychology from the University of Vermont in 1974. Dr. Rawson conducted numerous clinical trials on pharmacological and psychosocial behavioral addiction treatments for the treatment of individuals with cocaine and methamphetamine disorders. He has represented the US in numerous international meetings on methamphetamine, and he has led addiction research and training projects for the United Nations, the World Health Organization, and the US State Department, exporting science-based knowledge to many parts of the world. He currently is providing consultation on treatment of stimulant use disorder to 8 US states and several international projects. Dr. Rawson has published 3 books, 45 book chapters, and over 250 peer-reviewed articles, and has conducted many workshops, paper presentations, and training sessions. Professor Rawson will speak on the treatment of individuals with substance use disorder. Our second speaker is Dr. Mariano Hembra. He is an international fellow of the American Psychiatric Association and an honorary fellow of the Philippine College of Addiction Medicine and Philippine College of Psychopharmacology. He is a technical consultant and trainer for the World Health Organization Western Pacific Region, the Japan International Cooperation Agency, United States Agency for International Development, United Nations Office for Drugs and Crime, the Philippines Department of Health, and Dangerous Drugs Board. He has authored and co-authored several locally and internationally published articles on mental health, clinical psychiatry, and substance-related disorders, and is current Chief of Hospital of Don Jose S. Monfort Medical Center in Iloilo, the Philippines. Dr. Hembra will speak on the practice of Matrix Intensive Outpatient Program in the Philippines. Before we get started, I'd like to go over a few items so you know how to participate in today's event. You will have the opportunity to submit text questions to our presenters by typing your questions into the questions pane of the webinar interface in your screen. You may send in your questions at any time during the presentation. We will collect these and address them during the question and answer session at the end of today's presentation. Webinars and online events delivered and hosted by the International Society of Substance Use Professionals are provided for informational purposes only. They are educational in nature and do not constitute medical advice, diagnosis, or treatment. A recording of the webinar will be made available for you to watch on demand after the event. We hope you will stay with us for what promises to be an illuminating session. You will take away from this, if nothing else, a much more informed perspective of stimulant use treatment. And now, it is my pleasure to hand over to our guests, Professor Richard Rawson and Dr. Mariano Hembra. Welcome to the webinar. The screen is yours.
Thank you for the technical help, and I will try to go quickly. Yes, I've been doing work with people with stimulant use disorder now for over 40 years and have tried to contribute to developing evidence-based treatment for the treatment of cocaine and methamphetamine individuals with those disorders. I want to just quickly start by giving you a reference to an excellent article published by Dr. Martin Paulus, was published a couple of years ago. The major theme from this is that individuals who have chronically used methamphetamine have significant altered brain state. That is, you're dealing with people whose brain has been damaged by the use of methamphetamine. They have significant cognitive deficits, and you need to take that into consideration when providing treatment. We know they have altered both short and long-term cognition, and as you're delivering treatment that involves cognitive processing of information, you need to be able to make the information simple, clear, and you need to repeat it because people won't retain much of the information. There are many other medical and both neurological and cardiovascular issues involved. Some of the clinical challenges with individuals who use stimulants are these. Currently in the United States, the methamphetamine we're seeing is much more lethal than it's ever been in the past. And we're seeing high rates of overdose death associated with methamphetamine, and that's a new thing for us. You see some of the other clinical challenges that are common. I won't go through those. These are some others. The major clinical challenge we have in working with people who use stimulants are they're very difficult to engage in treatment and very difficult to retain in treatment. And that's really the most important thing we should focus on, because if people are in treatment, we see far lower rates of death than if they're not in treatment. So at a very basic level, getting people into treatment and keeping them in treatment are substantial priorities. Right now, there are currently no FDA-approved medications for the treatment of individuals with stimulant use disorder. We've done a lot of research on this and have really spent a lot of time looking for medications. These are some of the medications being tested for use for methamphetamine use disorder, but at present, none of them have approval for that purpose. And so we really don't have good tools on the medication side for helping people with methamphetamine use disorder. However, we do have behavioral treatments, and that's what I'll review right now. This is a quick status check of the behavioral treatments. There have been recently 7 meta-analyses or big systematic reviews where they've taken all the literature on treatment of methamphetamine use disorder, all the treatments, and summarized what works and what doesn't work. And in these meta-analyses, one treatment approach, contingency management, has had by far the most support. And I'll give you a couple of quick examples. Contingency management first is a technique employing the systematic delivery of positive reinforcement for desired behaviors. In many places, the way that's done is that people earn gift cards or some other tangible rewards for giving drug-free urine samples. So the patient comes in, collect a urine sample. If it's negative for stimulants, they earn something like a gift card or a prize or some kind of reward that they want. And that reward paradigm will result in a reduced use of methamphetamine. Sounds very simple. It is very simple, but it is a challenging technique to get used. But if you do use it, here's some evidence. This is a review by a group of authors from the World Health Organization published several years ago. They've reviewed a large number of studies, 50 studies with 7,000 participants. Their conclusion was contingency management was the most efficacious and acceptable in both the short and the long term. This was another review done in 2020, reviewed 44 studies. Contingency management intervention showed the strongest evidence favoring outcome. And there's several other reviews like that that I won't go into. In conducting contingency management treatment, it's important to find a behavior, pick a behavior that you want to change that's related to people's becoming sober, getting abstinent, and reward that behavior with something they want, some kind of tangible reward. In the US, we're using gift cards. People can get groceries or can buy gasoline or can buy other things they need, and they earn those by giving drug negative samples. Now, the reward has to happen immediately. They only get the reward when the sample is negative, and our entire treatment approach is very positive with them. We're really encouraging, and we really try to help them earn these cards and earn the rewards. So first, you have to define the target behavior. In many cases, we're using drug-free urine samples. The reward has to be delivered immediately. The immediate reward at the time they give you the sample, they only get the reward when they perform the target behavior. And the entire time we try to provide this in a positive, encouraging, reinforcing context. There are a number of app-based deliveries for contingency management, and these are some of the ways that you can have people, and they can do contingency management virtually over an app. There are some other treatments that I want to talk about. Cognitive behavioral therapy, we're going to talk about the matrix model. I was one of the authors of the matrix model, and we used a great deal of cognitive behavioral therapy. CBT is really the sort of the foundation of the matrix model and is a talk therapy, and our next speaker will describe that in detail. But CBT really is the basic form of therapy within the matrix model. And this is an example of some of one of the skills that's performed, where we're helping people understand the context of their drug use, what causes craving, what some of the triggers are, where those occur. And with cognitive behavioral therapy, we're really teaching the patient a good deal of information about their addiction and what the essential behaviors are they need to learn. And I'll let the next speaker describe that. Another behavioral approach, which has been not so widely used as the matrix model, but which has good evidence of research, is the community reinforcement approach. That's another behavioral treatment that combines a number of strategies, as does matrix, it's a combination model. And the community reinforcement approach involves a variety of skills. The therapist often needs to be able to do all of these skills. As the patient come in, the rationale is, with community reinforcement, that you're attempting to help people find new sources of reward or reinforcement or positivity in their life. As you are aware, with methamphetamine dependence, both people get very engaged in their addiction, their life becomes obsessed with their use of their drugs. All the other behaviors get set aside. They apply the drug to their brain. It damages the reward centers of their brain, and they really have trouble holding on to a reason for getting sober and staying sober. Community reinforcement really helps them locate and engage in behavior in the world that's reinforcing. As you'll hear, the matrix approach does that as well. It helps people try to learn about their life and learn new behaviors and find ways of making recovery a rewarding event. So CRA is another effective treatment. These are some of the topics you cover. In all of these behavioral treatments that I'm going to talk about, except for contingency management, there are some very common themes: helping people understand their triggers, helping them with behaviors to be able to deal with saying no when someone offers them drugs, and developing a new repertoire of behavior. As I said, the matrix model is something we developed in in Los Angeles in about 20 years ago now. It was our attempt to apply the knowledge of the time to treating people with stimulant use disorder. The other one I've got listed is an approach called trust. Trust is something our group developed in the last 5 years. And this is a variation of the matrix model where we take some of the material from matrix and we add in an incentive program like contingency management, and we help patients engage in physical exercise. And so this is another package of therapies that we have that if anyone's interested, and you get connected to me, I'd be happy to send you this information. It's similar to Matrix. We've tried to update it a little bit with adding in contingency management component as well as exercise into the activities of the treatment program. And we've been training programs on that for the last 3 to 5 years. I did want to mention for people with stimulant use disorder, there's actually a pretty substantial literature now on the value of physical exercise. As I started with, when people use methamphetamine chronically, they damage the functioning of their brain. One of the areas they damage is the reward center. They disrupt the dopamine system in their brain. Physical exercise has been shown in a variety of paradigms to help the dopamine system recover. We ran a large study a number of years ago looking at whether this would help, physical exercise would help individuals with methamphetamine use disorder. We did a randomized controlled trial. Half of the people got exercise, half of them went to an extra therapy group, and we compared on a number of different interventions. Their exercise consisted of a very structured, very rigorous kind of exercise. They did treadmill, they did strength training of a variety of kinds, 45-minute sessions, and this was something that we tracked and measured very closely. Over the first 100 days of their methamphetamine recovery, and our trial was an 8-week exercise trial, 3 times a week. They went for an hour. And at the end of 8 weeks, we did lots of data collection on measurements. We found that their weight gain, which often occurs as people get sober from methamphetamine, their weight gain was reduced. We saw increased heart rate variability, which is a measure of the heart that shows that exercise helped improve their heart functioning, really made a very significant improvement. Exercise reduced anxiety and depression, reduced craving. We did PET scans with these patients before and after, and we found that physical exercise, this 8 weeks of physical exercise, improved the brain's functioning. The dopamine system recovered more quickly. It's the one thing I've done with people who use methamphetamine that helps them feel better, that gives them some sense of control over their ability to feel better. Because when you're in the early months of recovery, which we at Matrix called the wall, people are feeling very flat, nothing feels good, their life feels terrible. They can't generate any neurotransmitter to feel good. Exercise helps that recover and is one of the few things where if patients will engage in it, where they'll say, yes, I actually can feel better. I do feel some hope. I'm feeling some greater encouragement. And with our study, when these patients went out into the community, the relapse rate for those who got exercise was much lower. So it actually contributed to reducing their methamphetamine use for the follow-up period. I wanted, and here's some references, and these will be available to you if you want, but we published, I think, 10 papers on this. I think exercise, whether you're doing the matrix model or some other form, CBT or CRA, I think exercise as a component of treatment can really help the patients with their emotional reactivity. It helps them feel better. It gives them a greater range of emotional feeling. They're not as impulsive when they've done this. And so I think whatever other treatments you're doing, if you can encourage patients to participate in exercise, physical exercise, it can be extremely helpful to them in being able to understand the information, the other information, and effectively participate in treatment. I think it's one of the most underutilized tools, and it doesn't need to be done, in a gym with a trainer. It can involve walking, it can involve jogging, it can involve, playing basketball. It's the kind of treatment added component that can be done anywhere by anybody almost with not a lot of expense. The challenge is, how do you get the patients to exercise? And we haven't fully understood that yet. I want to mention one other promising treatment that's being investigated in research, and this is, they're doing some transcranial magnetic stimulation, putting a apparatus on the skull, adding magnetic fields, and they're actually helping the brain recover there. Again, with people with meth use disorder, they really have done significant neurologic damage to their brain. And in addition to our therapies, it really is helpful if we can help them get their brain recover. The only things we know of right now that do that, exercise does, and this brain stimulation may have some value. We're still in an early stage of researching this, but it does look promising. So stimulants are a serious public health problem. Contingency management is an evidence-based intervention. There are other promising treatments, and we need a lot more research to move our treatment more to an evidence-based treatment. That's what we were trying, way of introduction to the next speaker. That's what we were trying to do when we developed the matrix model. The matrix model, we took the information we had at the time, the knowledge we had, and we created this combination therapy. And that was what our intention was. And I'm very happy to see that it's being used around the world. So I'll stop there. Hello, I can hear you.
We're the only two left, I think. Okay. Okay, so good morning, everyone. I'm very glad to do this back-to-back with Dr. Rawson. I don't know if Dr. Rawson remembered way back in 2003, 2004, I was doing my fellowship at Johns Hopkins, and we were exchanging emails until I was able to go to UCLA Integrated Substance Abuse Program and got to be introduced to the Matrix program, and got trained by the late Sam Minsky, Dr. Rawson, if you still remember him. So I was one of his students when I trained there. So my topic is actually on the practice of the Matrix Intensive Outpatient Program that Dr. Rawson, Dr. Walter Ling, Dr. Jean Obert actually built for patients with stimulant use disorders. So, right. Okay, so my talk is focused on the following objectives. One is to talk a little bit about the prevalence of methamphetamine in the Philippines, and discuss the basic framework of Matrix Intensive Outpatient Program, and then present our own version of the matrix intensive outpatient program, something that we actually kind of adapted for the Philippine setting. So this data comes from the World Drug Report in 2022. One can see that methamphetamine use disorders are very much prevalent in the Philippines and other Asian countries. So these are the blue ones represent the stimulant disorder prevalence in Asia. And then specifically the ones in maroon or I'm not good with color. So the almost reddish one also is most of the stimulant type of uh, drugs, basically a majority of which are methamphetamine, are also being used in the Philippines. This was further supported by the data that we got from our local, the Dangerous Drugs Board, which looks at the profile of drug users in drug rehabilitation centers. So please take note that this information is coming from patients that are enrolled or are admitted in drug rehabilitation centers and does not represent the community sample. However, it gives us the idea of the top 3 substances that are being used in the Philippines. And number 1 of it would be methamphetamine, and second would be cannabis, and the third is ecstasy. So when I went there in the US for my fellowship, I was lucky to be trained in the Matrix Intensive Outpatient Program. So just like what Dr. Rosson has said, being one of the authors of this particular program, it was developed around the 1980s. And this was in response to the epidemic of cocaine and amphetamine abuse during the time in the United States. The program is a multi-element package of therapeutic strategies that complement each other and combine to produce an integrated outpatient treatment experience. So please remember that the Matrix Intensive Outpatient Program was initially conceptualized as an outpatient program. Okay, a set of evidence-based practices like motivational interviewing, cognitive behavioral therapy, practices were delivered in a clinically coordinated manner as a program, which was considered as responsive to the patient need. And I think what was also very significant and important in this particular approach was really it has a replicable protocol, primarily because it was highly manualized, and so it was so easy to adapt to the different settings or countries that are that may adopt this model. In the Philippine context, the MIP model was actually the MIOP model was introduced in the Philippines around 2007. Using the published manual that was, I think, produced by the National Institute of Drug Abuse, if I'm not mistaken. Selected during the time when we tried to introduce MIOP or the matrix approach in the Philippines, we selected certain government rehabilitation centers as the first line in terms of being able to get the technology and absorb the technology. And orientation and training on this model was done for these rehabilitation centers who participated voluntarily and were encouraged actually to establish their own outpatient program in the respective areas. During this time, there was no model or anything that the Philippines can kind of apply in an outpatient program. And knowing that there are a lot of methamphetamine drug users during the time, especially um, during the President Rodrigo Duterte's time, it's very important that the Philippines come up with an alternative solution. During the time around 2004 to 2007, the only model that was present in the Philippines actually is inpatient rehabilitation program, which uses the therapeutic community model. So most of the trained rehabilitation centers adopted the model using the manual and later actually uh, put additional modules based on their own needs and cultural adaptation. In 2018, WHO Philippines actually, in addressing the call of President Duterte when became the president in 2016, um, actually awarded a grant um, for the training of selected local government units to be trained on matrix intensive outpatient program. They call it the recovery clinics. This was a WHO Philippines initiated project. And eventually, um, when the recovery clinics were established, uh, they did operate for a few years until such time that because of lack of funding and because the recovery clinics were supposed to be adapted by local government units, which did not materialize, the recovery clinics actually stopped because of lack of funding support. The practice of the matrix intensive outpatient program in the Philippines were continued by the treatment and rehabilitation centers, as well as some of the private rehabilitation centers that wanted to adopt the program. So what is the matrix intensive outpatient model? So it is a model that is based on several study-based and evidence-based models like relapse prevention. Dr. Rawson mentioned that MIOP is really heavy on cognitive behavioral therapy. So it incorporates psychoeducation as well as family approaches and the 12-step program support. Okay. So the MIOP model, the original MIOP model, was a 16 weeks duration program, which is the intensive phase. However, continuing care can be done from 13 weeks up to 48 weeks or almost up to 1 year. It was composed of several groups of sessions. The individual or conjoined family therapy, which addresses the individual's problems as well as the issues on the family. The early recovery skills group sessions were focused on the first few weeks or months of the recovering drug dependent or patient. It is intensive in a sense that it looks at how the individual is going to adapt uh, to his environment, this time with sobriety in mind. So early recovery skills group gives individuals skills for them to be able to sustain the process of recovery during the early phase of recovery, which is actually the most difficult part of the recovery process. The relapse prevention group sessions, which is composed of 32 sessions, as well as family education sessions and the social support group. So this was the original model of the matrix. Since it is an outpatient program, it basically is scheduled over a 1 week period, and there are certain days that sessions are being held. This was the schedule that I think has been prevalent in Los Angeles when they were doing the Matrix treatment program. Please take note that all the sessions actually starts after 5 p.m. I think this is in response to uh, the characteristic of the patients that are enrolled, because most of them are actually working or going to school. So it's but practical and logical for the program to start at 5 p.m. or 5:30 until 8 or 9 p.m. The adaptation that we have in the Philippines is quite different. The MIOP was integrated in the inpatient setting, and therefore it was a full-time matrix-intensive outpatient program applied inside the rehabilitation center. I will discuss about the adaptation in the Philippines. So if we all remember, you can remember way back in 2016, the government of the Philippines under President Rodrigo Duterte launched a nationwide campaign to eliminate illegal drug use. They entitled it Operation Tukhang. In the wake of this national campaign, more than 1 million drug users actually surrendered to the authorities to seek treatment and social support. This unprecedented demand for drug dependence treatment services highlighted the capacity gaps of the existing treatment and rehabilitation centers for drug dependence. In response, the President issued an official order entitled Executive Order Number 4, providing the establishment and support of drug abuse treatment and rehabilitation centers throughout the Philippines. So at this point in time, the response was still focused on inpatient rehabilitation rather than outpatient. This order resulted into the establishment of a task force for establishment of and support of drug abuse treatment rehabilitation centers throughout the country. And the Department of Health acknowledging, the government acknowledging that drugs is a public health concern, basically, the Department of Health became a more active participant in the process of shaping programs. DOH particularly took charge of developing plans and mobilizing financial resources to construct treatment and rehabilitation centers. I should like to highlight that prior to this time, all drug and rehabilitation centers in the Philippines is actually managed by law enforcement agencies. And then eventually this was transferred to the Department of Health. On the other hand, the need to revisit the existing treatment and rehabilitation programs provided at TRCs has been pronounced among the local and international experts. The government of the Philippines also recognized the necessity to introduce an effective relapse prevention program to the TRCs. In this context, the government of the Philippines requested the Japanese International Cooperation Agency for its technical assistance, which led to the formulation of the project for evidence-based relapse prevention programs to drug dependence treatment and rehabilitation centers in the Philippines, as we call it shortly as the Project Interlap. The project was officially launched by JICA and the DOH and the Department of the Health in December of 2017. Okay, so this was the overall framework of the Project Interlap under the cooperation of JICA and the Department of Health. The project of introducing evidence and relapse prevention programs in the Philippines. Actually, the outputs of this program are two. One is the IntriPrep, which is applied in the inpatient program, and the other is the IntriPost, which is actually an enhancement of the Matrix Intensive Outpatient Program, taking into consideration local adaptations in culture and other practices in the Philippines. However, for purposes of time, I will just be discussing IntriPrep, which is the Matrix Intensive Outpatient Program applied inside the inpatient rehabilitation programs of the treatment and rehabilitation centers. So that particular project actually lead to these particular modules. No? So we have created 6 modules, and most of these modules actually were a product of a series of the technical working group meetings conducted more than 18 times during the project period that led to the development of the IntriPrep model, which is based on, like I said, the matrix model that was initially made for the treatment of outpatients in the US. These are the supporting materials that were developed by the technical working group, which is composed of Filipino experts as well as our Japanese counterparts, and the focus of which is how to adapt the matrix, especially the cognitive behavioral sessions of matrix, into the inpatient program. Through the series of workshops, the interpret treatment components by providing technical inputs took into consideration the unique culture and social background of drug users in the Philippines. The program was also field tested to ensure its practicability and applicability in 3 residential settings before we were able to release the final output. So you're looking at the final output. So this is the blue one is the manual, the service providers manual. We created also the patient's workbook, which is in English and in Tagalog. The presentation module for the psychoeducation sessions was also expanded, and it was done in English and Tagalog as well. Discussion topics for social support sessions were also presented in English as well as in Tagalog. A training kit or a specific module for how to train facilitators for the project interpret was also made, as well as a guideline for field evaluation, especially if you look at the assessment of adherence to the program, and certain standards were actually done for the Department of Health to be able to do the monitoring and evaluation for this project. Okay. Interpret comprises of 5 program components, and it is designed for psychological and social skill improvements in drug users. In principle, these programs, the components of these programs are conducted through 8 scheduled sessions per week. So like I said earlier, it also followed the same format as that of the matrix approach. However, it is done inside the rehabilitation center. Under the interpret, the sessions that were scheduled were incorporated into the schedule of the treatment and rehabilitation center vis-a-vis their therapeutic community schedule. Timetables were suggested, and it was noted and highlighted that interpret does not or will not replace the existing treatment programs that the rehabilitation centers are having, but instead it needs to be incorporated into the therapeutic elements of the therapeutic community as well. Different timetables can be observed depending on the availability of facilitators as well as on the needs of the treatment and rehabilitation centers. So I gave an example of the schedule, a weekly schedule of an IOP earlier, as it is in practice in the US. And here, in the context of a drug rehabilitation center, basically the schedule is the same, except that it is actually inserted or inserted in certain activities of the treatment and rehabilitation center. So it is actually incorporated in the weekly schedule as well. So under interpret, these sessions were actually incorporated. And again, I would like to highlight the goal of interpret is not to replace the existing treatment programs, but rather enhance the efficacy of their current treatment programs. So the cognitive behavioral component of interpret aims to help patients to understand their thoughts, feelings, and behaviors that may often drive them to substance use. The CBT sessions are conducted 3 times a week. So, and part of this cognitive behavioral programs also follows the recovery stages of patients while inside the rehabilitation center. This was the adaptation that one of the adaptations that we made, because PRCs are following the recovery stages. So the CBT was also incorporated in the different stages of recovery that the patients are going through. In this particular model, the the sessions last for actually about 6 months over a period of time. Okay. Unlike the 16 weeks that the original MIOP is, the duration of the MIOP was. So these are the training program component. I mentioned about it. So aside from the manuals, we also added a module for training program, something that future trainers or facilitators that would like to train other personnel, for example, in the treatment and rehabilitation centers can follow. And these are the basic modules that we created for the training program and the target personnel. We made sure that it's not only the clinicians actually that will be trained, but we also want to make sure that even the treatment and rehabilitation top management or administrators would have some form of understanding of what interpret is and what how it is conducted in the respective rehabilitation centers. Additionally, the public health partners that we have in terms of the DOH regional health offices also attended the first part of the training program for them to be oriented as well about Interpret being implemented inside the rehabilitation center. The rest of the modules actually are focused on the training of facilitators. Okay. So in the training kit, one of the things that we actually put there is the facilitation standards that we established for the CBT sessions, the CBTR sessions, psychoeducation sessions, as well as social support sessions. What is unique here is that we have a CBTR, and CBTR actually means that cognitive behavioral therapy review, taking what Dr. Rosen has said, that most, if not all, of our patients who are using stimulants as their drug of choice actually would have significant cognitive issues. And that is something that was observed as well and was given feedback to our technical working group by the rehabilitation practitioners. So the review, the CBT review happens about 1 hour every end of the week, the purpose of which is actually to kind of review the topics that were done for that particular week, to make sure that understanding or application of the different CBT sessions are done by the patients or clients. So we also kind of made standards on the operations as well as assessing the operations of the Interpret model. So we created the standard operating procedure, which looks at facilitation steps and facilitators' action. The quality standard was also formulated, and it looks at content of the session, motivational interviewing facilitation style, management of group discussions, elements of the session, as well as time allocation. So we use this as a standard when we do monitoring, and we have standard checklists for these particular areas that we want to assess when we look at the application of the model. Okay, and the last, which is actually the guidelines for field evaluation. These guidelines provide actually practical guidance in conducting field evaluation and providing guidance to clinical and administrative staff members in better implementing Interpret at government treatment and rehabilitation centers. So in our case, as being part of the technical working group, we actually do travel across the country and visit all these treatment and rehabilitation centers. We make them present about and observe them when they do this facilitation when they conduct MIOP or sessions, CBT sessions, and we actually observe them using and checking the guidelines as well as giving them feedback. So it's a very useful tool to actually look at how the CBT sessions, for example, the psychoeducational sessions are being done, and it's also a good tool in terms of feedbacking to this particular facilitators, how they perform in certain parameters that we have established and agreed. So at the later part, a qualitative research to evaluate the applicability of Interpret was done. And the study actually were purposefully selected based on the inclusion and exclusion criteria of patients. It looks at or tries to answer three research questions. How did the introduction of Interpret change the residential services provided at TRCs? How did the introduction of Interpret change patients and facilitators' attitudes and behaviors at TRCs? And what are the challenges in implementing Interpret? We included 7 government-run treatment and rehabilitation centers for this particular study, and I will not go through the methodology anymore. So I'll just perhaps go to the outcome of this particular study. So there were 2 participants in the study. One would be the clients themselves, and the second are the facilitators themselves. So in this particular study, we have a total of 21 clients who are enrolled in this study and a total of 35 facilitators who participated in this particular study. So perhaps we should jump to the results. There were key themes identified by patients and facilitators. And when they responded to the questions that were done, and by the way, the assessment was done using a semi-structured interview format. Okay. So the different domains or themes that were identified were actually attitude and behavior of patients, attitude and competency of facilitators, the relationship between facilitators and patients, treatment planning and reviewing process, efficient and standardized treatment services, and monitoring mechanisms of patients' recovery process. The key themes are here on the right side. So I would be glad to share the slides with you later on for you to go through this, but this is the result of that particular assessment. Okay. And of course, we were also keen on asking the facilitators what were the challenges that they experienced during the implementation. And there were 4 that were identified. One is engaging family members in psychoeducation sessions. Second is lack of facilitators. So it looks at the lack of human resources in the rehabilitation center setting. Securing a conducive place for conducting sessions, given that most of the rehabilitation centers are actually problems with a lot of patients and little space for conducting these sessions. And of course, since the reproduction of the patient's workbook for CBT sessions is very material in terms of making patients or clients participate in the CBT sessions, the reproduction of this particular workbooks, for example, took its toll in terms of the cost that the rehabilitation centers have to look into. In other words, they have to add more budget for just for the workbooks alone. Okay, so what are the key implications of this study? One is improvement in personal and interpersonal aspects involving patients and facilitators was present. Better management of treatment services was observed. The study showed that the conduct of the Interpret corresponds to UNODC key quality standards for drug treatment services, namely patients are treated with respect, interventions are evidence-based, service has patient record system that facilitates treatment and care. So another quantitative research study to evaluate the effectiveness of Interpret is currently underway. So the project conducted research to quantitatively evaluate the effectiveness of Interpret at 3 rehabilitation centers, and a randomized controlled trial method was done. So the thing is, we are still in the process of collecting data until the end of February, and of course analyzing the data. So for those who are interested, you can follow up with us later on, and hopefully we can publish this study in terms of looking at the efficacy of Interpret applied in the inpatient program setting. So I guess that's the end of my lecture. So thank you very much for your kind attention. I would like to mention all the technical working group or all the people that I work with JICA, our Japanese counterparts, as well as the other officials of the Department of Health that made all these things possible right now. So again, thank you very much. Back to you, Dr. Ben.
Thank you very much, Professor Rawson and Dr. Hembra. We're now going to begin answering the questions submitted during today's presentation. As a reminder, you can still submit questions through the question pane in your attendee control panel. We'll try to accommodate as many as we can. The first question, I think, can be directed to both speakers. It reads this way: I'm from a third world country, and we don't have vigorous models of therapies in the country as far as I'm concerned. There might be some unknown psychosocial support program like MHPSS, the mental health and psychosocial support, where those types of therapies are provided. The question is, they wonder if matrix model and these therapies that have been discussed today can be initiated as a startup, they say. And can trained laymen provide motivational interviewing and other types of therapies? I guess these therapies. Maybe Professor Lawson, maybe you would want to comment on this first before Dr. Hembra.
Yeah, my comment would simply be that the matrix materials that we put into the manual can be used in a variety of settings. As Dr. Hembra described, and how they adapted them was really an excellent, very systematic process. And that's great when that can be done. But in many places that can't be done, but the materials themselves can still be used as a set of material that people can use with patients as they can see the patients, as they can get the patients to come and work with them. It doesn't have to be done in the formal structure of the matrix program. I would suggest that if you have some patients with methamphetamine use disorder, using those group materials, the worksheets, as you can get them to be worked with the patients, I think can be a good place to start as to get some services going, to get the routine down of treatment, patients coming in, interacting in a way of learning new material. And it can be done in a variety of different formats. Dr. Hembra, interested in your comments.
Yeah, I can relate to that, because when we brought back MIOP in the Philippines, we're kind of in the same situation. So what we did is just actually go through the manuals. One of the best things about Matrix is really it's highly manualized. You just have to go through the manual and all the exercises there, all the topics that need to be discussed, how it is to be discussed, everything is there. So you can probably start with that, similar to our experience. And you know, as you go through the manual, you begin to develop certain ideas that may be applicable to your setting, and you can actually tweak it like we did, or some of the TRCs did for their outpatient programs. So that's the beauty of the Matrix manual.
Yeah, thank you. I think a second part of the question was on the providers. So the question here is, can trained laymen provide motivational interviewing and other types? So I guess the question is, what would be the level of competencies and the necessary training for individuals who want to start up these programs? Professor Lawson, maybe you have some ideas on this for the question.
Well, of course it's optimal. It's best if you have people who have good, educational foundations and understand the delivery of therapy and understand the principles of motivational interviewing. But if you're in a situation where the people who are available to work with patients don't have extensive training, part of the reason we manualized Matrix and we wrote it all down was to give people with less experience, with less formal training, a set of material to use to talk with patients about their addiction. And the same is true with motivational interviewing. Motivational interviewing, if you really want to become an expert at it, takes intensive training and lots of role playing and all sorts of stuff. But I think people can review motivational interviewing materials that are on the web and other places, and they can start to get some basic skills. So yes, I think that a wide range of personnel, getting more people into helping roles as working with people with addiction is positive. And I think starting with where you are, with what your education is, giving these manuals and these therapies, and trying to work with them. If you can get some supervision from a clinical supervisor or a formal therapist, that's better. But if you can't, I think the materials are very usable by people who haven't had extensive training.
For me, just do the manual, read it, and perhaps do the best that you can. Although ideally, the matrix was for clinicians in general, but if you look at the specific topics and how it is handled, how it is discussed actually in the process of a session, anybody who has interest and some knowledge on basic things about addiction can actually deliver the module itself. So just look at it. I mean, and do what you can do with it and make some adjustments. That's the beauty of the matrix, the manual that used by Dr. Rawson and this.
Thank you to the two speakers. There are a few questions here related to the different stages, I guess, of the phenomenon of stimulant abuse. So one of them is, can you describe the therapies for detoxification? They call it the detoxification period for the stimulants. So that's one of the questions on the chat box. Can Dr. Lawson give some thoughts on this?
Well, when someone is in actual withdrawal from methamphetamine, they need to sleep and eat, and they're not really in much of a condition for therapy. Their brain isn't really processing much information. And if you're talking about an acute withdrawal period for the first 3 to 5 days after they've stopped heavy intensive use, trying to do any kind of therapy with the person in that brain state is almost impossible. You're just trying to help them start to get their brain operating again. The early recovery material in the Matrix manual is really designed for people in the early stages of recovery, but I guess it depends on what you define the withdrawal period. If you're talking about the acute, where they've been using for the last 3 weeks and they need to sleep and get that first 3 or 5 days, they're not going to be very, their brain isn't going to be very available for therapy. If you're talking about the first 2 weeks, 3 weeks of the early recovery, then the early recovery materials are useful during that period. But I do think that for someone who is been very profoundly addicted, who comes in, who stops using and really goes into acute withdrawal, while they're in that acute withdrawal state, you're not going to get a lot of therapy done during that period. They really need to focus on eating and sleeping and getting their sort of brain back in gear.
Yeah, and if I may add, during the acute withdrawal stage, the cognition of clients usually are really in a mess. So if you look at doing early recovery as CBT, then you may not be able to get I mean, they may not be able to gain much from the therapy. They need some time to withdrawal and to get out of the withdrawal phase. Maybe if they get to a better cognitive functions like 2 to 3 weeks or a month later, then maybe one can try looking at applying the early recovery stage. But based on our experience as well, sometimes you need to tweak as well the sessions in the early recovery phase, primarily because they might still be cognitively challenged and may have difficulty understanding certain points there. So what we do is actually sometimes we split one module into two, or actually just to make them understand bit by bit. Or sometimes we just actually just do the repeat the same module a week after if we think that they have not actually took advantage of the session in the past week. So those are small adjustments that you can make depending on your patient's cognitive levels of function.
Thank you, Dr. Hembra. I think we still have time for one more, and so this focuses on relapse or multiple relapse. So there's a question here regarding your recommendations on therapies for this situation, especially for multiple relapses. Professor Lawson?
Well, multiple relapses happen. My overarching principle is trying to keep the people connected to treatment, and people who are connected to treatment, who are still participating, whether they're relapsing or not, if you can keep them coming in and participating, their chances of dying from an overdose are reduced. So sort of the bottom line, keep them connected. You will see people who will have multiple relapses. If you can, it's nice to add something to give them some additional tools, something like exercise as part of their program, or providing some additional family support. But I think the overarching principle is try to stay encouraging to them, try to help them understand relapse is part of the process, that people do relapse, and we don't have control over exactly when it's going to be successful into long-term recovery. But if they keep working at it, they can definitely make major improvements in their lives, even with an occasional relapse. We used to think of relapse as being an either-or thing. Either they're successful in treatment or they relapsed. We don't think of it that way anymore. It's like other chronic illnesses. People have periods where they're doing well, and then they may have periods of relapse. But if you keep them in contact and keep working with them, you often can see people who have those multiple relapses make it to a more stable place.
Mm-hmm.
Thank you. Dr. Hembra?
Well, I agree with Dr. Rosen. One of the important things is to make them come back and come back and come back. I think the other thing that's important, I think, would be the relapse analysis. Looking at how the patient relapsed, like Dr. Rosen mentioned about, we are now looking at relapse as a process and not a positive or a negative thing. So we try to look into the processes or the stages or the steps that the patient underwent until he went into relapse. And we will be discovering a lot of things that we can do to intervene to stop the process of relapse. And I think that's also one of the central components of mindset of MIOP. Do a relapse analysis and teach patients to identify their thoughts and similar other topics that are very important.
Yes, I'm glad Dr. Hembra mentioned that. The relapse analysis is one of the things I think that we developed that was one of the most useful specific tools to work with people. It takes them from being hopeless about their relapse to being something where they can learn something. You don't want it relapse, but if you do, you need to learn from it, and that's what the relapse analysis helps people do. Thank you for mentioning that.
And it empowers them actually to be able to deal with the relapse and not get too frustrated, so they will be depressed and not to come back anymore. So it gives them hope as well.
Thanks again to Professor Rawson and Dr. Hembra, our experts for this morning, for answering those questions and for their great presentations. It was really a pleasure to have you with us. Ladies and gentlemen, this concludes the webinar. Thank you all for attending. We hope you learned something new and enjoyed the presentations. You will receive a follow-up email within 24 to 48 hours with a link to review a recording of today's webinar. We always appreciate your feedback and suggestions. Please use the link in the follow-up email to fill out the feedback survey. On behalf of ISSUP and our presenters, thank you for joining us today, and have a great rest of your day.
Thank
Mabuhay
you.
from the Philippines.